innately, we are different from each other, so we're not going to live the same number of years. Those differences are acceptable. It's the disparities where you didn't get what you needed and therefore you're dying early. That's what we're trying to eliminate. I am an associate professor of epidemiology and biostatistics at the UCSF School of Medicine. I am also an associate director in the Cancer Center, and my area of direction is community engagement, and I'm the founder of Umoja Health.
What does health equity mean, Dr. Rhoads? We hear this all the time now, constantly. We hear about DEI in healthcare. Like, what does it actually mean on the human level?
So health equity really refers to everybody getting what they need. I think we started in, liberation movements with the language of equality. But when it comes to cancer, the truth is different people need different approaches. And so equity refers to people getting what they need based on what they're presenting with. And I think that distinction is really important. I agree with you. The word is now being overused. It is now being substituted for disparities, which I think, if you really think about it, I'm a linguist in my undergraduate training. And so I'm always paying attention to the implications, the connotations of the words that we select. When we put the word inequity on top of disparities, what people are trying to refer to is the fact that these are addressable. Because if something is inequitable, it means it can be shifted towards equity. But by putting it over and covering over disparities, what we are effectively doing is trying to erase a state of being that exists as a result of inequity. It is the final common pathway of inequity. You end up with disparities. So as long as we have inequities, we're going to have disparities. So we need not try to layer, cover over disparities by talking about inequities. It is true that's where we can take action, in inequities. But what we want to stay tuned for is the elimination of disparities by intervening to promote equity.
What drew you first initially, even to medicine, right? This is personal. What was that first step to saying, I want to be a doctor? And then, and then what drew you specifically eventually to the area of cancer?
So I was in one of these, pipeline programs before we had the DEI language in 1985 and 86. And so at the age of 14, I worked in a lipid metabolism lab at UC San Diego. And I worked there for 2 summers in a row. And I remember telling my mom, don't get excited, I'm not going into medicine. But the money was really good. And so like all this cash, and it was really exciting. But the people in the lab took an interest in me, and I liked science. So it was fun for me to be in a laboratory. That helped me in college because I needed a job and there were jobs available in labs. And so I was able to easily slip in. I had already had a little bit of experience. And really, it was the folks in my lab who encouraged me to think about medical school. I was not thinking about that. As I mentioned, I majored in linguistics. I was not interested in being in the rat race that my pre-med friends were stressing out and staying up all night. I had no interest in that at all. But then as a junior in college, and thinking about like, okay, what does a linguist do for a job? I decided to pursue the coursework to go to medical school. So I didn't decide really until I was almost done with college. And then I took all the undergraduate courses that were needed in order to sit for the MCAT and make an application.
Wow. But you were primed really from a very young age. You then, you pursue medicine. And at some point in med school, something personal also happened, right? That really shaped you.
So I knew that it was a big commitment. And I knew that I needed to be making a conscious choice about going to medical school. So I'd taken all the coursework, but then I decided to take a year off in between college and medical school. And because I had worked in a lab, I was referred by my lab PI, principal investigator, to a lab in Washington, D.C., where I decided to move away for a year. And just take some time and figure out, is this really what I want to do? I don't want to be on a treadmill and then get to the end and find out that this isn't what I really want. So I wanted to take some time to make a decision, casually take the entrance exams. And I worked in an HIV lab at the time. And my family is from Virginia. So, I had a car, so I would leave DC and drive to Virginia on the weekends and spend time with my favorite cousin and my favorite aunt. During that period, as I was applying for, once I decided to go ahead and apply for medical school, I was talking to them about, interactions that Black people have with the healthcare system. And my aunt was, expressing this something missing from her interactions with healthcare. And what she talked about was, she said, I remember distinctly, she said, I just want to be able to go to a clinic where when you walk in, people know your name. And, and I think of Cheers, of course, you open the door, hi, Jeanette. But what I really realized is she was asking for community. She wanted to feel like she was part of something, not like she was going into a situation where she would be judged for the choices that she had made or how she lived her life. But what I didn't know at the time was that she had breast cancer, and nobody in the family knew it at that time. And by the time I was the second year in medical school, the cancer had become so advanced that she was not even offered surgery. She was treated just with chemotherapy, and she died in the hospital. All of things that are just contrary to, having choice, being supported, feeling that warmth that I think people need in a vulnerable time. Because I'm first generation college graduate and first doctor in my family, I thought, let me make a phone call. And as a linguist, I thought maybe I could translate. Because I know that medicalese is being spoken and that people are probably not understanding what's going on. So when I called the hospital in Virginia, I was given a little bit of information. The beginning of it was, I had asked if there was a specialist involved, and I was told, oh, well, general surgeons do, take care of breast cancer, and we're not operating anyway because the tumor's too large, and just a lot of kind of dismissive interaction. And then by the end of the conversation, the person on the other end of the phone said, are you a nurse? Because clearly I had enough medicalese to get by as a second year medical student. And I said, no, I'm a medical student. And then they hung up on me. So that really, stuck with me in terms of like, what kind of setting is that? And what are the problems here? Like, I just knew there's some problems here. This is not how it's supposed to go, especially in that kind of vulnerable time. So that kind of set me on a course of my original pathway in research, understanding the experience, initially understanding the experiences of Black women facing breast cancer and their relationship with surgeons. I had no idea I was going to go into surgery at that time, but I was interested. What is that relationship like? Is it kind and caring? Did you feel taken care of and that somebody was looking after you? Or did you feel like, I remember one of the questions was, did your doctor make a U-turn at the bedside, at the foot of the bed, right? And then it got me thinking about the fact that she never got radiation, which based on the description of the tumor, she needed radiation. And that's when I started to look into and think about, and this was by this time, many years later into my surgical residency, does this have anything to do with the difference in resources that are available? So going back to my aunt and asking the question, was there radiation available at that hospital? And as it turns out, there wasn't. So that's why she wasn't offered radiation. And so that started to inform how I think about disparities, because my suspicion was that you get the kind of care you get based on the institution that you select. That kind of brings us back to our question of inequities, right? Are people able to get what they need based on where they choose to get their care or where they're forced to get their care based on their circumstances.
You were very conscious of this from the very beginning, even before you officially started seeing patients, and becoming a surgeon and all these things. So in these many years since then, what have you learned? Like, what is that summary of, and I know maybe it's changed. I mean, has it changed over time, or are we still at the same place depending on where you go for care?
And are we still there? Yes. The answer is yes. What most people don't know, because we don't have, for example, a consumer reports on what hospital you want to go to. I was involved with some groups that were trying to put that together for California. It just never really got off the ground. And so people don't know that where you go determines what you get. People aren't aware that you might plug in, well, I have cancer, so, and my zip code is whatever your zip code is, and find the nearest 6 hospitals and look at their quality ratings, right? But there were some efforts to try to promote better outcomes by ranking quality and letting providers know where the high quality is, letting the insurance companies know where is the high quality care. And there were several studies around 2005, 2006 that came out showing that nobody was using those rankings. And so referrals were being made based on personal networks. And whenever you talk about personal networks in a field of higher education, you know that those networks are going to be segregated. And so you can imagine how that can play out, especially with the history in this country, for example, of Black doctors only being allowed to train at certain institutions, only being allowed to practice in certain areas and in certain hospitals, not being allowed to join professional societies with white physicians. That then is going to determine where your patients can go to get care. And I can get deeper into the policy implications and how that's played out now, and how California hospitals are still segregated by race, ethnicity, but also by insurance status. That all came from policy. Redlining and exclusion and segregation in all of those layers that I just talked about, in the education, and then where you can practice. That's where the patients are able to go.
Things that you're describing, people might think, oh, that's from before, but what you're saying is no, it's very clearly still here.
Well, it is. And so let me just give you an example. So my aunt was treated in a safety net hospital, and that's a hospital that has to take you as a patient regardless of your ability to pay. Your county has designated where those hospitals are. There's some other designations I won't get into, but your county is pretty much determined, where those are. And those hospitals largely serve patients who have no insurance, or Medi-Cal when we're talking California, Medicaid when you're talking nationally. And so now what you've got across the country are what are called, actually what I dubbed in 2008, high Medicaid hospitals, or hospitals that serve a disproportionate share of patients who have Medicaid or no insurance at all. And what you'll find is those tend to be your safety net hospitals. So their revenues are not that high because they're being paid by an insurer that doesn't reimburse at a high rate. For example, Medicaid pays somewhere between 5 and 15 cents on a dollar. So if your total hospital bill is $10, you may get $1.50 back to the hospital to reinvest in their plants, property, and equipment. Cancer care is super duper expensive. A radiation machine costs money. A specialized CAT scanner costs money. Well, if your revenues are low, those are not the investments you're going to be making. So that's how you start to see a segregation of patients of color using high Medicaid hospitals for cancer care, and then having to get whatever is available. And that may not be the high-end PET scanner, may not be the CAT scanner that can slice the pancreas into thin enough slices that you can see a teeny little tiny tumor, right? And if you need radiation and that hospital doesn't have some kind of agreement with a place to provide radiation, you're not getting radiation. That has a direct impact on outcomes. So when we looked, just one last point, when we looked back in about 2014, 2015, we used data that's publicly available, and we asked which hospitals provide care to a high percentage of different racial and ethnic groups. And the one very notable thing is that white serving hospitals do not overlap with Black serving hospitals, and that they only overlap with Asian serving hospitals, and that Hispanic and Black serving hospitals are completely segregated. There are hospitals in California where we can show you that they have had 0 Black patients over a period of 10 years. So it really is segregated in a way that has not been amplified.
I mean, this is really surprising to me, I guess. It shouldn't be. But I thought, okay, a lot of this is socioeconomic. If you live in an area, you know, and your means are not, and then you're limited in terms of your option. Maybe you do go, your closest hospital or your most accessible one is a safety net hospital. But you're saying, no, this is down racial lines. So can you help talk about that? I know there's another layer there, right?
Yeah. So the socioeconomic factors like income, education, employment, those do track along racial lines as well. So it's hard to pull them apart. But what I will say is we did publish a series of papers asking the question, why do people go where they go, right? What is the median travel distance that people will go in California to get colorectal cancer treatment? Because we have to think about travel distance, right? So we found that the median travel distance was 5 miles. Now, there's all kinds of discussion that can be had about that. 5 miles doesn't seem like a lot. If you have a car, that's short. If you're on the bus, it might take longer. If you don't have access to either of those things, it's, 5 miles is impossible. So we first asked that, and we used that as a marker. And then we said, okay, what proportion of each racial and ethnic group live within 5 miles of a National Cancer Institute Comprehensive Cancer Center or a high volume center? And it turns out that racial and ethnic minorities are the groups that live closest to these centers because they tend to be in non-rural areas in California. So they live closer. Then we said, okay, well, of those who live within 5 miles, are you using them? And a lower percentage of racial and ethnic minorities who live within 5 miles of an NCI center or of a high volume center, we're using them. So then we said, okay, well, what's going on here? So we asked, is this because of insurance? The answer is no. Insurance did not move the needle. Sorry. Insurance was not statistically significant in its correlation. It did not explain this difference. But then we asked, is it possible that the neighborhood characteristics determine where you go? And so we used education as the socioeconomic factor, and it overrode travel distance. It neutralized the effect of travel distance. Travel distance did not matter. What mattered was neighborhood education level. So I know when I give this presentation on this series of papers, a lot of people will say, oh yeah, I knew it. They just don't know better, right? But as I mentioned to you before, lots of people know better and still don't pick the highest quality hospital, including insurers, including referring providers. So the way I try to explain this is we looked at neighborhood level education. So it's not the education of the individual, it's the characteristics of the neighborhood. And what we say is you are like your neighborhood. You're like your neighbors in terms of your health behaviors, because that is kind of a marker of socioeconomic status. Like, what's your neighborhood like? In your neighborhood, you're kind of in the range, with everybody else because you can afford to live there, because you chose to live there, all of that. So what we're saying instead is that neighborhoods develop their patterns of where they get their care. And that trumps quality and it trumps travel distance. So if that's where my aunt went, if that's where my grandma used to go, if that's where my mom went, then that's where we're going because that's our hospital. The problem is that if you peel it back to another social determinant, which is redlining, and say, like, where are people allowed to live? Then you become like your neighbors and you establish a relationship with the hospitals that serve that neighborhood. And those tend to be the safety net hospitals for racial and ethnic minorities.
Can you, and I know there's a lot here, so it's not easy to boil down, but if you were to summarize to someone who has no idea, what are those nuances? And you've done a great example, carrying out Umoja, and we'll talk about that too, but what are the solutions?
Actually, that's a great segue because as I said, what's happened is a relationship has been developed. Whether that relationship is for better or for worse, right? You might not be aware that you could get better outcomes somewhere else because that's always where everybody's gone. And I think the thing that we have forgotten in medicine and healthcare is we've forgotten our own humanity. We've forgotten that we are also simply people. And that is the one thing. I don't care if you're green, purple, brown, whatever. That's the one thing I have in common with everybody who's not an animal, not a dog, or, but we as humans have that in common. And what that means is that we need to be making relationships with our communities that are around us in the same way we would be thinking about and making relationships with our friends. Now, we don't have to tell them all our personal secrets, right? But we shouldn't be thinking about those relationships as I have all the resources and you do not. And there's that way in which we otherize the patient. It happens in medicine, just in that doctor-patient interaction, just the fact that it's doctor-patient. The doctor's coming with some information. The patient's coming with a lot more information than the doctor could ever have because they're living in that body every day. But there's the way in which we exalt the doctor, like the doctor could never be the patient, which is a ridiculous proposition. Similarly, as institutions, when we partner with community, we otherize them. There's a lot of paternalism. There's things that we want to hide and that we don't want to say. Failing to recognize that actually, if we came with transparency and we said, these are the hard parts, let's work on the hard parts together, that actually is going to build trust faster than it all looks good and everything we do is great.
What are some of the things people could say to be more transparent and just, kick off the right conversation to lead to a good relationship?
Well, first of all, it's an acknowledgement that this one interaction we're having is not our whole relationship. This is the beginning, right? I will see you again. And in the process, as a human being, I will be making some mistakes. You will be making some mistakes. We will have some miscommunications. But the commitment to the relationship is that we will work through those together. So I think that's what can happen in the doctor-patient interaction. I think in the institutional interaction, there also needs to be some humility. So part of that is, number one, coming out of the building, getting out of the building and being in community in whatever way you can. You don't have to be in community as the doctor. You can be in community just as an individual human. Experiencing a life in the same geographic, territory as other people, but obviously having a different experience. I think that's what helped Umoja move along. But I also think, people buy into Umoja and link into Umoja because even though it's focused on COVID for the moment, it came out of our relationship with our partners around cancer. We're here because we want to be in partnership. So it's year-round, non-transactional community engagement. That's the investment that is absent in all this DEI conversation and DEIA and however you want to rearrange the letters. The commitment to humility and to transparency is what is always, always missing. So I think that what we're doing with Umoja by being out in the community and by being out in the community without my UCSF t-shirt on, right? I'm wearing an Umoja t-shirt, just like the volunteers who are there, just like any other medical provider volunteer who comes out. We all look the same. And I think, to me, it gets me back to what my aunt was looking for. She's looking for her neighbor to be at the clinic, right? To be the person to welcome her in. We do not train in healthcare providers the skill of seeing people fully in their full humanity without judgment. We provide rules of what's good and what's bad, and then the people who are doing it wrong, you judge them, right? And then if you layer racism in there, then you have a quicker judgment for different people because there is a belief that they are inherently not good or inherently better than other people, because racism can go both ways, right? It cuts both ways. It's not just thinking people are bad, it's any judgment at all. So we need to build our relationships, and that's where you're going to get people wanting to be part of the solution, wanting to promote your study, wanting to participate in your study, because that's not the primary thing you asked them for. The primary thing you asked them for was a relationship.
I love that. That's really powerful what you just said. Can you give an example of, on the ground, on the human level, how what seems like small steps and small decisions can actually really change someone's mind if you really want to get them involved.
I mean, I've been doing community engagement work since 1993. And, you know, in 2020, I had a number of eye-opening kind of revelations. The first was, you know, we started Umoja as United in Health District 10, bringing COVID testing into the community when people didn't have access. So we were working in Bayview, southeast sector of San Francisco, large African-American population, relatively speaking to the rest of the city, and then Sunnydale as well, where we picked up Pacific Islander communities and then Latino population all throughout. When we were done, I remember having a conversation with my department chair and saying, you know, it really strikes me that the tents for the testing efforts were all just white tents. There was no signage anywhere that said Public Health Department or UCSF. And I said, and I think that's actually why people were willing to come. And then to bolster that, like that was my suspicion. Then to bolster that, I had a participant that I was speaking to. I had no idea she had gotten tested at our site, but she brought it up and said, the only reason I answered your survey questions was because my neighbor was the person asking the questions. Because we kept checking throughout that, like setting these pop-ups, well, they were, you know, mass testing sites at the time, we would track of the volunteers who are working the site, do they match the demographic distribution in the neighborhood, right? Are we capturing the neighborhood people? Are we engaging the neighborhood people? So that was a big deal when she said that. I only answered because it was my neighbor. Otherwise, I wouldn't have answered any of those questions, right? The trust was already there. The relationship was already there. Okay, so that gives us an advantage. And so by the time we finished our first run of Umoja in the fall of 2020, African-American people had gone from being the lowest testers in the county to being the highest testers in the county. And we didn't even, yeah, it was awesome. We didn't even work the entire county. I have to say now, we get a lot of calls that are like, somebody has cancer, we need a second opinion. How can we get into UCSF? People who would not have otherwise even considered talking to UCSF. And these are people from our Umoja community, COVID focused, calling us about cancer. So it just goes to show that the relationship is what matters. We're not looking at people as needing transportation and childcare, or you're poor and you don't know anything and we're ministering to you. No, we're saying we need what you know, because that's going to help us get the information out. And that is what I think is going to help move us truly toward health equity.
Again, so powerful, everything that you just described, right? You talked about othering and these, you know, othering just period across the board. What's the message about why it's so important for everybody?
The otherization piece is really central to a lot of how I think about, you know, any of the work that we do in any community. Because you can be otherized and be a short white man who is not aggressive, right? There are just, you know, a million ways to be otherized. And what I go back to is the way to avoid otherization is to recognize your own humanity, because that is the link that you have to every single other person on the face of this earth. And I guarantee if you spend more time, you'll find other similarities and other commonalities. So you don't have to separate yourself in that way. And I think that's core to what the problems are in healthcare.
My last question is on the generation. So I know some people I've heard say, well, you know, this lack of trust, you know, if it's distrust, and specifically we're talking about, you know, the Black community, if we talk about Tuskegee or Henrietta Lacks and all these, well, as the generations go on, younger people, it's going to be fine. Well, not it's going to be fine, but slowly that'll take care of that. But in your experience, you know, because I know in talking about the COVID situation and Umoja and your experiences there, you met a range of people, right? In terms of age, with the same lack of trust. I mean, yeah, if you could speak to that, that would be great.
So think about this. If you don't have a relationship, why would you expect to have any trust? You shouldn't. Think about your own personal relationships, right? You just met somebody, you don't automatically trust them. It takes some time of building up, how you work together, how you relate to each other. So what I would say about like over the generations, you might think, well, the young people are kind of unaware because it's happened so long ago in the olden days, as we used to say when we were little. But actually, the young people are where it's at because their minds are flexible, they're open, they're willing to see, disparate treatment and privilege and access to opportunities. They can see it. It's not really a lack of trust. It's an appropriate response to a history of untrustworthy behavior. Right? There are reasons to be suspicious, which is why it matters to be in community outside our walls, because that's where you can start to break down the things that have happened in the past, because now something's happening in real time.
I appreciate that. In cancer specifically, what do you see as the next real feasible steps in addition to what you're talking about?
Well, so if you address the inequities, you're going to get rid of the disparities. We've shown it in colon cancer. We've shown it in acute myelogenous leukemia. We've shown it in gastric and pancreas cancer. So we know that if you address the inequities, you're going to get back to differences, and differences are okay because that's innately, we are different from each other. So we're not going to live the same number of years. Those differences are acceptable. It's the disparities where you didn't get what you needed and therefore you're dying early. That's what we're trying to eliminate. So addressing inequities is going to get us there. I think there is a process that is in play. So the building the relationship is the beginning of the process. Having the next step from this relationship is actually having the community influence the research questions. We all are carrying millions of mutations right now, but we're not a million cancers, right? Are there environmental exposures that are selecting a mutation and saying, okay, now you're going to start growing, you're going to be a tumor? And I think that kind of research is going to be so importantly informed by advocates and by community partners, because they're going to be able to tell you the stories about what's happening in their neighborhoods. So when we see cancer clusters, we can start asking very specific questions about cancer promotion in those specific spaces. And again, that's another example of centering the community in the research question. So that's not about, we can apply our scientific approaches, which are all very cutting edge, but we're applying them to questions that are directly relevant to people who are living regular lives outside of our institution. So the next step is developing questions that really hit home so that our results are relevant to the people that we think we're trying to serve and be in partnership.